This is just a quick video on anterior shoulder instability. Most shoulders that dislocate go out the front. That is, the humeral head or ball goes in front of the shoulder. And when it's out, it sits in this sort of position and then is reduced back this way. So you can see it goes into the front of the shoulder blade, the ball comes back. When it dislocates, the ligament and its attachment to the bone, the labrum, are what's commonly injured. The most common activity is some sort of sports or recreation, like a fall skiing, biking, climbing, maybe making a tackle in football, wrestling. They can dislocate for sometimes what seems somewhat minor trauma, and other times it's a more significant injury. They can reduce spontaneously or with the help of another person, trainer, and obviously sometimes they have to go to the emergency room. A common treatment once in the emergency room is to be given a sling, and the literature on this is really fairly thin, and so we don't think the sling gives you any extra benefit of healing the shoulder. It can be fine a few days to help with pain, but we actually like to get people out, get them moving, and typically we even start some physical therapy to help with motion and also with shoulder strengthening. When a shoulder goes out, the concern really becomes happening again. And the risk of this is very age and activity dependent. So a young male under the 20 has the odds that are very high, maybe 80% or so over time, that they're going to dislocate again. Whereas if you did this at age 35 for the first time, the odds of you coming out again are much lower, which might impact how you wish to be treated. Older patients, though, over 35 to 40 or so, have a significant potential for rotator cuff tearing, and so they need to be evaluated to be sure that at the time of that dislocation, they don't have a tear. Return to contact sports can also increase the risk, and this can make it so that we have to make decisions on how that shoulder should be managed. When a new patient comes in for shoulder instability, obviously we talk to them about the circumstances and how many dislocations and so forth. We look at x-rays to say, are there breaks, chips, other pieces that we may have to worry about in their management. And then commonly after that, we do some advanced imaging like MRI or CT scan, if indeed the patients want to pursue further management of the problem. Many patients can be managed conservatively, and once out of the sling, as we discussed, can be doing some therapy, motion, and strengthening for the shoulder. It's a bit controversial, but we feel that patients under the age of 22 may need to think about having a surgical intervention after that first dislocation in order to try to minimize their potential for recurrence. One of our concerns is that with repeated dislocations, you can do more damage and injure some of the bone of the shoulder. So in this example, we can see that the socket, the bone has been chipped away, and on the back of the humeral head here, we've lost a little cartilage and bone, so that when somebody puts their arm up and maneuvers the shoulder, it becomes easier because there's not as much bone to support and they can come out. With multiple dislocations, we worry about this extra bone injury, and that may necessitate a more complex intervention. Commonly, it's done open, and we need to do something to replace that bone. So if the bone is pretty normal and other aspects of the shoulder are fairly normal after reduction, our preference is to do an arthroscopic repair. This is less invasive and has fewer postoperative complications and is a good treatment to help correct the problem for the patient. But as more dislocations occur and more damage occurs to the shoulder, then we're forced to consider other potential options. It should be noted that unfortunately no operation can make you bomb-proof. That is, recurrence can happen regardless of the surgical approach. Surgery can significantly decrease the odds of coming out in the future, but we can't eliminate them. Now, this video is to give some basic information, answer a few questions. It's not intended to be exhaustive on the topic and cover all the risks of treatment and all the other alternatives for every patient. Further details on a specific situation clearly needs to be discussed with your surgeon.